you very much also for putting into relation what we are discussing right here and now. So it makes us perhaps a little bit modest with our expectations, but also with our ambitions for changing actual policies. But still, I'd like to open now for question and answers first amongst the politicians between us and you. And I'd like to begin with one question was already brought up on the first panel, that is the evident need to have qualified information on both sides, on the caregiving side, within the politicians, but also on the side of the public and the patients. So is it, for me the question is still, to what extent is it a political issue, this guarantee or guaranteeing of increasing information, of making sure that we all have access to qualified information? To what extent is it just an issue of experts, also medical professional, and to what extent it actually needs policy changing or revising for us politicians? For me, that's a question concerning who has got access to what information and then access to what services. I just want to give you one example. In cancer treatment, we know a lot about the metabolic system of patients, and we could offer much more individual treatment by doing more genetic testing, which is already available, but most of the patients are not offered these tests because of costs, because of lacks of policy guidelines, and some patients get it just because they are privileged. The similar question arises with the treatment or diagnosis of rare diseases. Who has got access then to what information, to what testing, and to what services? There are increasing gaps in this field, and for me it's a huge question to what extent we need to react as politicians and to what extent that's up to the experts. So that's my first question. I don't know whether we should collect some 2 or 3 questions and then hand it to the experts so we can leave the discussion a bit broader.
Thank you. I would like to return to Martina's first words. You're talking about during pregnancy tests and about Down syndrome and other things. And I know we discussed it when we were collected for about a year ago, that in the future you will be able to predict quite a lot about the coming child. In these papers you write about the parents' rights to have a full screening and the parents' rights to take choices on that background. I would like to hear if you've been discussing where should the limit be. Do we have to make it stop somewhere, or today in some cultures it's you want to decide whether it's going to be a girl or boy, and you might be able to predict sometimes something about the IQ. Should there be a limit there? And the next question is, will we be able to control it? Because some of these tests will be available on the market, and you can go out and just buy them. And then what do we do?
So all of us have questions, so I can put you a question.
Yes, I'd like to thank the presentations, but I'd like to focus on the the fact that now we have a tension between experts. Because in the first panel, everybody said no problem, not predictive power in these sequences, is no problem at all, only to control the misuse and so on and so on and so on. And now we discuss that in a lot of fields there are predictive power in these tests, and how to organize ourselves in order to allow that this prediction will not offend fundamental rights. We need to know how to attain that. And afterwards, another tension, how to make the correct decision in order to put the correct money in this kind of tests, because we have a lot of investment made in it, but there is a huge gap between the amount of money we put and the clinical results of that. And so how to combine the correct balance in investing in science, and of course not forgetting the key factors in order to attain that health indicators. And another political tension, perhaps with the discussions led sometimes subliminally, I don't know how to say it in English, subliminarmente, in order to make public systems evolution in only protecting people around key factors and forgetting all the protection we need from public health systems. And I think between all these tensions, I'd like to hear something from you. Thank you.
Now, next and for a moment, last question.
Yes, well, very quickly. In the earlier session, there's been somehow a downplaying of sequencing with respect to lifestyle and environmental factors. I don't know enough to question that, but definitely there is another part of, say, the possibility of a more balanced, say, address and targeting of drugs, and on the basis of the genetic knowledge. I think that this is also important to minimize the side effect of drugs and to deliver that in the right place and then in the right moment. And that could be extremely important for any treatment, to my understanding.
So then I give the floor to the experts.
It's so many questions that we have enough for an hour or so I guess we have to prioritize here. Maybe to start with the question about where to draw the line with severe medical problems or with being a boy or a girl or IQ. So when I said the goal of offering a reproductive choice is to have parents make their choice and not to force them to do something, that of course is related with the fact that in healthcare we only offer something if it is considered worthwhile. So there's two levels of decision making. First, it is in a healthcare system or not, and then second, parents can choose whether or not to use it. And I forgot to mention that first one, but it's a very important implicit one. If now you would buy a commercial test, it is possible to have a non-invasive natal test and get the sex of your child quite early. You know from Asia that in some countries, if people don't like to have a girl, they might want to use the same technology to avoid the birth of a girl. Or if you would have a family with already 3 girls and you want a boy, or 3 boys and you want a girl, then you might use that technology. But it is not a medical problem. From the medical professional side, we would say we should try to avoid that kind of uses, and also IQ or eye color or whatever. So in the offer of prenatal testing, I think we have to focus on medical problems, but there medical professionals cannot do that alone. So there we do need politicians to draw the limits of what could be given back to parents. And sometimes might also say, but that's rather paternalistic. If you know that my child will be a boy and I want to give the room of my child a blue color, please tell me in time. Well, I mean, if we consider that not the responsibility of medical doctors, maybe we should really draw a line there and say it's simply not allowed to give back that information, say before 20 weeks of pregnancy or so. Still another aspect, even if the discussion may become a bit blurred also. This issue of information and how can we take care that everybody is using the information in the best way. Much of the information that is generated in research now is in very early translational research. So it's written up in Science and Nature, and after that nothing is happening. So in the prioritization of research funding, this issue of we need more translational research in terms of things that we really consider very promising and well, we don't think it's a hype, but it's really a hope. We should also have a study, follow that up, see whether it really works, to have translational work in the sense of doing pilot studies, developing professional guidance, see whether that's going good or stopping it again. So in the funding of research, we need definitely more translational research. And finally, in the field of rare diseases, and here I'm following up some of the things that also my colleague was already mentioning, we need perhaps more preliminary approval. So if something is only for a small group of tumors or a small group of patients, you may want to have very promising drugs already on the market early onwards, but then again with very good post-marketing surveillance. So we may need not only the EMA approval after a randomized controlled trial with thousands of participants, but also just for patients that 1 or 2 or 3 would use it, but to find other ways to prove the evidence that this is really efficient. And in statistical terms, there are models to do that, and I know that also the European Medicines Authority is looking into that. But if we really want to go to personalized medicine, we also need to personalize the early use of that kind of medication. That's my comments for the first point.
I think the orphan drug regulation may be applicable here, but that is another discussion. I would like to comment on 3 points. The first one, perhaps, which was the question that was asked by Vittorio Prodi, that, for example, pharmacogenetics may be an important method in order to avoid side effects in patients that take some medication. This was and still is a big hope, that's for sure, but like everything in genetics, it turned out to be much more complicated than originally expected. I mean, there are only a very few cases where you really have a one-to-one relation between a gene alteration and a reaction to a certain chemical or medication. In most cases, it's a group phenomenon that you know that this group probably may react differently, but you cannot really predict this for a certain patient. And on the other hand, there have been many biochemical tests which were able to monitor the drug reactions. And last thing is that most of the adverse drug reactions, up to 60% or even more, are not due to pharmacogenetic reactions, but to wrong prescriptions, not adherence to schemes, and interactions between different medications. That's very well known. So the effect of pharmacogenetics may be there in some cases, which is very helpful, but in most cases it's probably not as much as was expected in the first time. My second point is the need to have qualified information and who is responsible for it. Perhaps I think I think it's a shared kind of responsibility as well. Much of it is professional responsibility to have exact information about the clinical utility and validity of the test and so on. And I think this is really a very, very big task, because to evaluate the clinical utility of a test, a companion test, for example, it's quite elaborate and it requires clinical testing, like the introduction of new medication in general. And I don't see how this could really be diminished. This has to be done, and if this information is available about clinical utility, then it can be integrated into the healthcare system and should also be reimbursed by the insurers. But I think this is the duty of the profession, and informing the general population about what is going on, and to take up genetic information and knowledge where it is where it makes sense. There we would have to talk about genetic literacy and other things, and health literacy in general, and sometimes I'm a little bit depressed about it when I read how little people know about healthy kind of food and living. I think we really have to do a lot in this respect, but not only about genetics, but about health and staying healthy in general. The last point is maybe it's not really an answer to Madame Roseira how to do correct policy decisions. I mean, I'm not the one to answer this, but I mean, probably there are different ways of doing good policy decisions, which is not only to proceed with caution, but doing pilots. For example, of introducing new ways or methods or procedures, and also public health procedures, and then wait until the result is there, and then making new decisions. I mean, it can only be an incremental step. I think it should. I can't imagine that it would be a wise decision to say, now we put such and such money into public health genomics, and but go stepwise and try to find out what may be worthwhile in public health and what maybe just not paying out.
I would like to refer that we as medical geneticists, and there is always the question, what is the medical genetics profession going to be if everything becomes genetic, becomes genomics medicine? And of course, the usual answer is that we still have to deal with patients with rare diseases. We still have to counseling with families. But one of our major roles is also education of other physicians, beginning with general practitioners. I think they are the ones in a better position to deal with a family because of their formation and their practice, formation of the public, at the high schools. I think it's very, very important, and we have the tradition of our institute to go to the high schools and provide short lectures about health, about genetics, and also receive in schools and have open days and open doors. And that's really something that is extremely important, and will make realize people what is predicted and what is not predicted in DNA, because some things are and some things are not. So I'm more really addressing the other question of the tensions. I think the tensions are more apparent than real. There is a lot in DNA that it's not predictable, and has very low predictive value at the current moment at least, and that's really for the common diseases which are more easily preventable by other means, as we heard, by changing in lifestyles. But we cannot forget at the same time that we have 22 to 23,000 genes. There are 7,000 known genetic diseases, and we know the genes for half of them. These are really predictable. When the cause is monogenic, the genetic testing will be of great importance to the patients and to the families, both in diagnostic and in the predictive context. It makes all the difference to set that barrier, and what is preventable and what is not, and how easily it is. And by education we can also make regulators, professionals understand better the predictive value of genetic information, and not to request tests that should not be requested in the first place. There are a lot of tests with no clinical value that are reimbursed within the national health system, and while sometimes the needs for patients are not covered in the same way, we must remember that we have a national plan for rare diseases in Portugal that was approved in 2008 and has not left the paper yet, so nothing has been done since then. It was one of the first approved. In this very house where we are, in 2005, one of the first laws in Europe for discrimination, anti-discrimination for genetic information was approved, but it's still waiting regulation of some of the holes that were left in it for later on. And for 5 or 6 years we have proposals ready by the experts, and we have proposals ready for regulation of genetic services and of genetic testing, and licensing of genetic testing, quality of genetic testing, not just external quality assessment, but also the need for accreditation, and nothing has happened since. So politicians and regulators really have a big deal in dealing with this, and it's really something that we must solve quickly, because that will decrease costs, that will benefit the population as a whole, and it will help to focus the scarce resources that we all know are available for healthcare.
Thank you very much. That's the problem with shared responsibility. It actually needs both sides, and that's another big challenge we are facing. A short last comment.
It's a very small point related to the data collection. I just wonder if we shouldn't be a bit more restrictive with the data collection, not because of all the good reasons we've already discussed, but mainly because a very large number of data collection are made only for the phenotype, without any sort of information on the phenotype. And I suspect that for substantial proportion of these database, they won't be used for very spectacular things if they do not have very good data, for example, on diagnosis. In my country, I know several hospitals, they are beginning systematic genotyping their patients with the consent and probably in good conditions. But they are relying for the diagnosis on the hospital diagnosis, which is not a reliable way to think about it. I think it's quite a concern just to collect these data at a huge cost in general, without any sort of use. And I suspect that many of these data will be used only for the genetic of longevity or that sort of thing, so relying on very hard inputs, but for other purposes it could be difficult.